Hello, and welcome to ID Talk, Answers from Infectious Disease Experts. I am Dr. Scott Olson, a pediatric infectious diseases specialist at Banner University Medical Center in Tucson and associate professor of pediatrics at the University of Arizona College of Medicine. Along with Dr. Nathan Price, I am the Arizona AAP Infectious Disease and Immunization Co-Medical Director. This podcast has been created to answer questions from our chapter members about everything and anything infectious disease and immunizations related. Thank you for tuning in today. This is the week of June 2nd, 2025. Now, because we're doing things a little bit different, and in June we're only releasing one episode, Dr. Price and I will be dividing up questions on today's episode. So I'll be handling the first question, and he will be answering the remaining two. Let's go ahead and get started with the first question. The first question comes from a listener who states, the CDC issued a recall on ready-to-eat foods from Fresh and Ready linked to a listeria outbreak. The sandwiches and snack items were sold in multiple states, including Arizona. Can you speak about the procedures in place for when a manufacturer has confirmed listeria in their products, and what clinicians should consider for patients who may have consumed these products? Now, when we talk about food recalls, there are two separate federal agencies that are involved with getting food recalled when it's contaminated. So first of all, there's the FDA, or Food and Drug Administration, which regulates about 3/4 of the national food supply. And then an organization under the USDA umbrella called the Food Safety and Inspection Service, or FSIS, regulates meat, poultry, and some fish and egg products. And it sounds fairly straightforward, but recalls are undertaken when a product is thought to be either contaminated, unsafe, or mislabeled. Now, these recalls can be initiated either by the responsible company for the product or regulatory agencies, as mentioned previously, either the FDA or FSIS under the USDA. The manufacturer of the contaminated product is responsible for the costs associated with the recall process as stipulated by consumer protection laws. When a problem has been identified and a recall has been initiated, recall notices are then published by regulatory agencies, and the companies are also required to publish information online about the recall process, including guidance targeted to consumers regarding actions to take to determine whether or not they have purchased a recalled product and what to do if they find that they have. Of note, the FDA does have a recall subscription service that people can sign up for to stay up to date with current recalls. In addition to publishing recall notices, the companies are then responsible for removing the recalled product from the market, including stopping all production of the affected product. Both the companies and federal agencies often then perform investigations to determine the root cause of the contamination to prevent any future similar incidents. Once a problem has been identified and the recall process has been performed, the federal agencies can then terminate the recall based on status reports performed by the implicated company if they can effectively demonstrate that the contamination has been addressed. While doing some background reviewing to prepare for this question, I found a recent report from the Public Interest Research Group that found in 2024 there were around 300 separate food recalls in the United States, with 1,400 associated illnesses, 487 hospitalizations, and 19 deaths, which is actually double the number of hospitalizations and deaths compared to 2023. And because both the FDA and the USDA have been impacted by recent focus on deregulation and reduction in forces by the current administration, it is a little concerning that we may be seeing more of these food-borne outbreaks in the next several years if those cuts do impact those agencies' ability to effectively regulate the food supply. If we look more specifically at the outbreaks in 2024, most of the illnesses reported were related to only 13 of the outbreaks. So, for example, some of the large ones included an E. coli contamination of onions that were used in McDonald's hamburgers, which led to 104 illnesses, 34 hospitalizations, and 1 death. Additionally, there was a large outbreak that I think a lot of people heard about with listeria contamination of boar's head deli meat that was associated with 61 illnesses, 60 hospitalizations, and 10 deaths. And while most people think about meat products when we talk about foodborne outbreaks, only about a fourth of illnesses in 2024 were due to meat and egg contamination, with the remainder being due to produce contamination. So, for example, there was a large outbreak of salmonella contamination in cucumbers that caused more than a third of all hospitalizations in the prior year, highlighting the role of uncooked foods with potential agricultural contamination that can lead to illness if not washed appropriately. And though food contamination with bacterial pathogens is the main focus of this question, I would just like to highlight that a large percentage of food recalls in 2024 were due to undeclared allergens in the food product. So that's also a large issue when we talk about food safety. Now, going back to the original question, the writer asked what patients or customers should do if they think they've purchased recalled food products. First, I think it's important to encourage them to read recall instructions carefully, as many of the details with the specific recall, including how to manage or dispose of the contaminated products, is going to be included in those notices. Oftentimes, the products can be returned for a full refund, or the company will note how to dispose of the item safely. Additionally, it's important to point out that while most people will hopefully not think of doing this, it's important to tell people not to either donate or give away the implicated products, obviously, as that could potentially lead to illness in the person who eventually consumes it. Areas in the house that have come in contact with the affected food product should be washed and sanitized, including refrigerators or counters. Additionally, after handling the implicated product, patients and individuals should make sure they wash their hands with soap and water. Again, as I mentioned previously, a lot of times this is due to external contamination from agricultural practices. There's no specific recommendations with regards to testing individuals who may have been exposed and are asymptomatic, but if a patient thinks that they may have consumed the affected product, it's important to tell them what sort of symptoms they may be experiencing and remind them to seek medical care if they experience them, with the most common symptoms being fevers and nonspecific systemic symptoms, along with gastrointestinal symptoms. And then if a patient develops symptoms, it's important they're evaluated by either the primary care provider or a other healthcare provider. And then if it's thought that this is related to consuming the affected product, that can be reported through either the FDA or the USDA. And there we have it, a primer on the food recall process. So with that, I'm going to throw it over to Dr. Price, who's going to answer the remaining questions this week.
Okay, well, thank you, Dr. Olson, for those wise words. Let's move on to the next questions. Question number 2, can you please provide the latest recommended guidance for antibiotic stewardship in the outpatient setting? This is an excellent question. So antibiotic overuse is becoming an increasing problem, and the CDC estimates that 2.8 million people get infected with resistant bacteria every year, and they estimate that this leads to 35,000 deaths annually. And over the years, more and more emphasis is being placed on trying to prevent this, with a lot of the resources going to the acute care inpatient settings. But there is a lot that can be done the outpatient side as well. When we look at overusing antibiotics, developing resistance isn't the only issue. You can have other things that can happen, like developing allergic reactions, developing C. diff infection. It often leads to higher cost to patients, and there's lots of other possibilities. There are a lot of good resources out there for antimicrobial stewardship, and what you may not know is that the AAP Red Book has a really nice section starting on page 978 that I highly recommend that you take a look at. So there's a lot that can be done in the outpatient setting. So first things first, we should make sure we're using the right test for the right situation. So if you don't go looking for something, you're not going to find something that you're tempted to throw antibiotics at. For example, children under the age of 1 rarely get C. diff disease, even though they're often colonized with a toxigenic strain of C. diff. So we really shouldn't be testing for C. diff in most of these patients. Strep pharyngitis is another major problem. We know that up to 20% of children during the wintertime are colonized with streptococcus on their tonsils. So if you go looking for it, you're going to find it about a fifth of the time. And we know that most children who show up to the clinic with a sore throat have something other than strep pharyngitis. So we need to make sure that we're testing for the right situations. We shouldn't be testing for coughs and runny noses and rashes in the setting of sore throat. Of course, there are some exceptions that apply. We also need to be really careful with using the expanded nasal swab PCR tests. I'm specifically referring to the ones that have the expanded bacterial pathogens on there, things like strep pneumo and H. flu and Klebsiella. I see lots of patients that are referred to me in clinic that have gotten antibiotics over and over again for positive nasal swab tests. And when you take a close look at what's really happening, they have viral disease that they get swabbed and then see these positive tests, and folks see that you've got a pathogen on there and feel tempted to treat. And really what's happening is that they're colonized with those bacteria. So I really wouldn't use one of those expanded pathogen panels to make a bacterial invasive disease diagnosis. The exception to that could be things like pertussis and mycoplasma. When we're using our urine tests, we need to make sure we're getting the right specimen, and we really should not be sending cultures off of bag specimens because the contamination rate is so high. The next thing is we need to make sure we're not prescribing antibiotics for viral illness. And this is tough because there's a lot of overlap and it's hard to tell, is there a bacterial superinfection in certain situations? But remember that most pneumonias in preschool aged children are caused by viruses. And so we don't need to be prescribing antibiotics unless, of course, it's classic for bacterial superinfection. Sinusitis is another one that gets overdiagnosed, and make sure you familiarize yourself with the clinical criteria to be able to distinguish bacterial from viral infection. And remember that not all bacterial infections require antibiotic therapy. For example, many cases of otitis media can be treated symptomatically and will resolve on their own without antibiotic therapy. When it comes time to use an antibiotic, make sure you're using the right one for the right job, and ideally we should be choosing the one with the narrowest spectrum of activity. For example, most cases of outpatient to inpatient community-acquired pneumonia with mild to moderate disease in a fully immunized child can be treated with amoxicillin or ampicillin. When it comes to treating urinary tract infection, later generation cephalosporins usually aren't indicated if the patient is already clinically improving on narrower spectrum therapy, even if the organism is resistant in vitro. This is where a simple phone call can be helpful. You can call, and if they're doing fine, you can keep on with that same therapy. Okay, let's go to the next question. Question 3. Given the increase in measles and other infectious disease cases and decrease in herd immunity, are there any change or new recommendations for approaching infectious disease prevention in immunocompromised pediatric patients? Another great question, and this is something that we're going to have to deal with more and more as vaccine hesitancy and vaccine refusal increases in our patients and the general population. And as was mentioned in the question, we're seeing an increase with the outbreaks in things like measles and pertussis and other vaccine preventable illnesses. And unfortunately, our most vulnerable patients can't receive the same protection even if they want to. So we need to continue to do our best to keep the protection around them as strong as possible. So at this time, there isn't any new specific recommendation for this patient population, but if a local outbreak does occur, check with your local health department because they often have additional suggestions on what to do depending on the situation. In the meantime, we can increase our vigilance. So become familiar with the signs and symptoms of things like measles, mumps, pertussis. If you hear of a patient coming into the clinic that has symptoms of a contagious illness, take the steps to minimize exposure to others. For example, if you have a patient that's coming in with a history of fever, rash, and red eyes, and especially if they're unimmunized, think the measles. Meet them at the door, put a simple mask on them, and put them in a room immediately. If you have a negative pressure room, use that. If you're seeing a patient who has a cough, put on a mask. I've talked to many people who have gotten post-exposure prophylaxis with azithromycin because they found out later that the pertussis swab came back positive. And finally, familiarize yourself with post-exposure prophylaxis options for immune-compromised patients who get exposed to these diseases. And the Red Book is really a great resource for this type of situation. Of course, if you have other questions, feel free to reach out to the pediatric infectious disease provider in your area. Well, that about does it for this episode of ID Talk. Thank you again for listening. Arizona AAP members can submit questions for future episodes to id@azaap.org. Arizona AAP would like to acknowledge the generous support of the podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to infectious disease and immunizations in Arizona, or to become a member, please visit azaap.org. Thank you for all that you do. We'll see you next time at the next ID Talk podcast.